Okay, so we'll get started. Welcome to the live case in Lecture 5, Left Main and Multivessel Disease. I am Sripal, Bangalore, interventional cardiologist from NYU Langone Medical Center. I'm joined by my co-moderator, Dr. S.J. Park, and we have an esteemed group of panelists. We will start with, there'll be two live cases from Asan Medical Center, and we'll follow that with a featured lecture. So we'll go live.
Okay. Do-Yoon, Kang, Dr. Kang, can you hear me?
Yes, I can hear you.
All
Good
right,
morning.
great. We are many, distinguished moderator, panelists here. So you want to start your first cases.
Yeah. This is my honor to present the live case of the left main. I am Dr. Do-Yoon Kang from Asan Medical Center, and I will introduce my team. My assistant is Yeonwoo Choi, a senior instructor in the Chang-Wook Hospital, and Seung-Jung, our senior fellow of interventional cardiology. And Dr. So, please present the patient case.
Yes. Thank you, Professor Kang. I'm Kyusup from Asan Medical Center. Let me introduce this case. 71 years old male patient who was referred for effort chest pain, and he had no past medical history. Next. He had hypertension and dyslipidemia, and clinical presentation was stable angina functional class 2. Next. Electrocardiogram shows frequent APC. Next. And chest X-ray was normal. Next. Echocardiography shows normal average systolic function without regional wall motion abnormality, and treadmill test was equivocal. Next. There was a diffuse stenotic lesion at left main bifurcation to diagonal bifurcation. Next. Next. Okay. Next. So the target lesion is left main bifurcation to diagonal bifurcation, and we plan the Yves guidance PCI.
I will show you the angiography more detail. This is the angiogram that we checked today. This is RAO caudal view that shows the very severe disease in the proximal LAD, and some intermediate. It looks mild here at the left main distal bifurcation. Next. And here you can see that the distal left main bifurcation is diseased, and visually it looks that the proximal radiostium and circumflex has 50% of disease. And proximally there is severe tight stenosis, and you can see also the diagonal vessel disease. Next. This is a cranial. You can see diffuse severe stenosis of the LAD, and there is some. It looks like a collateral flow to the far distal PL branch. Considering the relatively small circumflex size, you would feed the distal circumflex or distal OM area. Next. And this is the unmagnified image of the proximal the cranial image. You can see the diffusely diseased LAD, and diagonal has some intermediate disease. Next. Which we try to check the Yves, but
Okay,
after wiring, the flow of the LAD was
Before you
decreased, so
treat
we
any,
apply small balloon.
Dr. Kang,
Yeah.
so I want to ask,
Yep.
is before you treat
Minus.
these cases, is it included the FAME main study?
That's right.
All right, so which one, the randomized, which angio-guided or FFR-guided?
The patient was randomized to angio-guided
Angio-guided,
PCI group.
right? So,
The FATE main trial compares FFR-guided left main PCI and angiographic-guided PCI, like
All
the,
right. So
the
we-
current guideline.
okay, recently we conducted a FAME main, randomized study, it's angio-guided and FFR-guided. And so,
Minus.
David,
Minus.
this is the main disease and some collateral to the circumflex diffuse disease. And so, what do you think? Is a candidate for surgery or?
Yeah, a definite candidate for surgery, assuming there are no contraindications, and I couldn't see that there were any. But this is a complex kind of distal left main, and also what's important here is that the patient has complex both proximal LAD disease and diagonal disease, and both are excellent targets. So he's a lot of good distal targets. So we would, certainly in our centre in the UK, and I'd be interested to hear what Mama says, but we would certainly be considering cabbage for this patient.
Cabbage first.
Yeah, I think in such cases, we tend to be objective, calculate a syntax score and see what it is. It is diffuse disease. I bet the syntax score is not more than intermediate at best.
I mean, it's got a CTO as well.
Yeah.
Right, so I think in the UK it would definitely be cabbage's first option for this case.
Slide minus. Slide.
Did you hear Dr. Kang? David Taggart
Yes, I
recommended
heard.
bypass
Yeah.
surgery. So, how would you do that?
I think the patient is also a good candidate for cabbage and also good candidate for PCI, I think. And this RCA does not look like CTO because we could check the NGO and the RCA flow was very good. And only very small, maybe far distal, the circumflex vessel is fed by the collateral flow. And because the patient was randomized to FATE main study and the angiographic guided PCI was selected, and I would treat the left main with the angiographic guided guidance. And angiographic guidance, it looks like more than 50% of the stenosis, I would treat the left main. And we progressed some bit next. And we wired into LAD and diagonal next. And after wiring into LAD, there's some flow, a sluggish flow, so I applied the small balloon 2.5 compliant, and then check the Yves.
Good.
Plus, yeah. Can you please show me the LAD Yves? First run. 이거 보시죠, 좋아요. This is the LAD pullback from the mid LAD. And
Just
mid LAD is relatively small, and from here, the relatively mild disease region with a vessel size is more than 3.0. And there's a little bit negative remodeling just distal to the bifurcation, and you could see that there are many branches coming into mid LAD. And this is the proximal LAD. That because we applied the balloon, so there you can see the balloon-related dissection at the 9 o'clock. Yeah. And here's the ostium with the severe calcified lesion and the high plaque burden at proximal LAD. And the opening of the LAD has the disease, and you
Which
can see
plaque
the
burden?
circumference
Where?
coming from the 9 o'clock.
Circumference.
And the left main itself is mild disease with a huge vessel size.
Actually, main itself
And we
is
also
not
check-
too much. Not too much
Yeah.
disease, right? Just the corona
that's
part,
right.
there's a small plaque burdens. However, mainly, what about the main ostial part? What about that one?
LAD
main
ostium
ostium.
보여주실래요? We just show the LAD ostium. Yeah,
How about, how about the
There.
circumflex ostium? I mean, have you assessed that more formally with Yves?
This is proximal
Yeah.
LAD still, right? Larger vessel.
This is proximal LAD
Circumference
and
coming in
ostium.
9 o'clock, right?
Yeah. definitely we need to evaluate the circumflex ostium by IVUS because in LAD pullback, the ostium looks okay, but in many situations, if we check the circumflex pullback, it's totally different. Would you show me the circumflex pullback?
Okay.
3번, yeah, okay. This is circumflex pullback. The caudal view 한번 보여주십시오.
Some disease, normal looking area.
And you could see that the mid LAD is mildly diseased, and proximal LAD, there's a big vessel, more than 3.5, and this is just opening. You could, would you show me again?
We cannot see that. So,
That's just
ostium.
there's severe stenosis. Yeah. We checked the IVUS and the size. The lumen size was 2.5, and the plaque burden was 75% at the ostium.
Very discrete narrowing, right?
Yeah, discrete narrowing.
Circumflex ostial part, very discrete narrowing, relatively 3.0, 3.5 so.
Actually, we retrospectively evaluated the IVUS pullback of the circumflex and the outcome after the crossover. And if the patient has the lumen size less than 3.7 and plaque burden more than 67%, and the acute event after crossover was more than 15%, the patient needed severe chest pain or shock or the acute closure. So actually, with that concrete data, we prefer to perform the two-stent if the circumflex ostium is diseased with a more than plaque burden like this, the 75% and lumen size 2.5. How does the panelist think?
All right, Dr. Louvard,
Yeah.
what do you think is it for the, IVUS findings?
I will analyze that as I would do in France. So in France, we don't using intravascular imaging. So we use QCA guidance, knowing that QCA is undersizing, but we can make some correction for the diameters. And about the localization of ischemia, this patient would have done cardiac MRI before the procedure to see, of course, the ischemia in the anterior wall, but also in the lateral wall corresponding to the circumflex. So my strategy will be a crossover. So I have not seen the diameters. So I imagine that it will be difficult to have a very long stent with the distal LAD, which is small, and the left main, which is huge. Probably we have to use two stents, one for the bifurcation with diagonal and one with the bifurcation with the left main. Provisional. And after that, we see the result on circ.
Any other suggestion?
Do-Yoon, I am Youngkeun. So actually, when I see in the left main to LAD regions, I think it's some calcified region is very tight stenosis. So I wonder that because in the LAD is a very feeding artery to making a collateral flow to the distal Hsieh. So what's your think about how can we cover the LAD stenting, because if we make it too more long and then too tight, maybe I don't want to make some compromise in side branches, because if we lose some side branches, it's not good for the patient. So could you imagine then how can we coverage the stent implantation in the LAD?
Yes, it's a very great opinion, and there's two problems, that the LAD is long, diffuse, and calcified, and second is there's many branches there. And when we measured the LAD lesion length, it was 38.5 from the mid LAD to the left main. So I think that I can cover a whole region with a 38 millimeter stent.
You want to just,
I believe
Doctor,
with the
you want to do the stent crossover, right?
For the diagonal and some branches. But the left main, I still think that the two stent would be more safe for this patient. And there another problem is the another branches like diagonal and septal. And intravascular imaging showed the septal opening is quite good, but diagonal, I can see some disease in the angiography. So I check the diagonal also with Yves. Would you show me the diagonal Yves? Two.
Yeah, I agree. I mean,
This
if you
is
look at
the
the caliber of the
prevent from
diagonal,
diagonal
that's a
branch.
pretty large diagonal also.
Yeah, that's right.
I mean, these are three bifurcations you
The
have
patient
here.
has the one big diagonal and one big RI branch.
You've got
and
three
distally, there's no
bifurcations,
other
and you're probably going to have to do a bifurcation distal left main
I was
procedure.
image central, please. We want to see the
Yeah.
bigger image.
This is
right,
the diagonal
great.
branch per bed.
Diagonal.
The vessel size is the distally 2.75, and the prox diagonal has some negative remodeling with the calcification. So the vessel size was 2.5 at there.
At the least
And you can
2.5.
see
Diffuse
diffuse disease of the diagonal branch. Here is the tightest region as you see in the angiography with the calcification. And
Insufflant
this is
calcium.
the opening of diagonal branch to LAD. I think there's some negative remodeling, however, it's quite some preserved.
I think the Yves is making many things clear here. I mean, compared to angiography, because it's very clear. Even the ostium of the diagonal is severe. So I think you're dealing with a couple of bifurcations.
Yeah, that's right. It's a very complex situation that I have the diagonal bifurcation disease and the left main bifurcation disease.
Right. So how would you do
Actually,
that?
Yeah.
We have a limited time, Dr. Kang. What would you do
Yeah.
that?
I have to deal with the many disease, but I wanna concentrate on the big things, not small things. So for diagonal branch, I do not want to additional two-stent or add other complex situations. So I apply the drop-coated balloon next. I set the size by the vessel size because there was some negative remodeling and the vessel size was 2.5 there. So I applied a small compliant balloon and then applied 2.5 drop-coated balloon with a paclitaxel coated balloon for 1 minute. And now I'm here. I will check the angio after the diagonal branch. Okay, DCB applying. Angio. There's some dissection of the
dissection,
proximal diagonal branch. You can see the calcification region has some dissection. And we check the Yves. Let's see the Yves. Yeah, diagonal branch. This is the Yves pullback of the diagonal branch after applying the DCB. This is the common situation when you apply the DCB to the diagonal or the other small branch. The vessel size is enlarged compared to before applying the balloon. And you can see the dissection at the 12 o'clock. The dissection is behind the calcium. And the dissection is at the LAD.
So
Yeah, but the flow is good, and I will more open the LAD, and then let's check the flow again. 3.5 NC, 3.0 NC 주세요. Because the prox LAD stenosis is very tight, it would compromise the LAD and diagonal flow. So after the opening the LAD with the aggressive NC ballooning, and then we can check again. And I hope that I can concentrate on the left main with the two-stent.
I think the
3.0.
bifurcation of the LAD and the diagonal PME flow is okay, and the dissection is acceptable. The problem is residual stenosis more than 30%. So that's a little bit of conflict of the DCB use.
Yeah, I'm also curious. I mean, for the panel, now we have a bifurcation diag LAD, and you're going to stent across that bifurcation. Would you actually do the DCB after you stent the LAD? Because now you've already done a DCB, now you're going to stent across that, it's possible you have a side branch compromise.
Yes, I will agree. So actually, what my strategy would be, no doubt, upfront to stand at the left main bifurcation. For diagonal, maybe we will just use balloon, kissing balloon, and see the effect. If it's patent, then I will just stand crossover, and at the end, I will do kissing balloon with DCB.
DCB.
24.
24.
Deflation.
I mean, I probably wouldn't have pre-dilated the diagonal because you've got a situation now that you've got quite a significant dissection, and I would be rather loath to leave it alone and just stent across it and hope for the best.
Yeah, and I think, I mean, this is the main reason EBC, stepwise provisional, would say don't dilate the side branch first.
Exactly.
Anyone would consider just like JL balloon or JL like microcatheter at the diagonal?
A wire is enough.
Sorry?
A wire is enough.
I think the wire is enough.
Yes,
If you choose properly your stand, you don't need to make a stronger protection with a wire. No problem.
Actually, it was the 15 minutes ago that I applied diagonal the DCB, and there's no change, and team flow is 3, and I want to ask panel that, in my opinion, I would cross the diagonal branch and concentrate the left main with the two-step.
Dr. Kang, actually, it's just a suggestion, right? Diagonal branch, I think is big enough. It's more than 2.5, almost 3 size. And you want to do no dissections after the DB. However, there are big dissection. Actually, we don't know, so the long term in terms of a dissection for like this one and so.
Yeah.
All right. Just
May I suggest something? We are speaking about provisional. Now we have a dissection of diagonal, so you can stand from LED to diagonal and kiss with the LED.
Right.
Only single stand.
Anyways.
Because the lesion on LED is short.
At this moment, Dr. Kang, so
Yeah.
I think I wanted to just two stand for the diagonal branches,
Diagonal branch.
and then so you're gonna have some another option for the main stem procedure, crossover and provisional treatment, etc. However, in terms of diagonal branches, I think it's quite enough to treat more than 2.5, almost 3, and so crush and another let's go ahead. You want it's your case.
Okay. It's a very complex situation, and when we meet, this is a common situation, then I treat the diagonal branch or big side branch with the DCB. The calcified region makes some dissection, and still we don't know whether it has no problem in long term. Okay, then I accept the SJ Park's opinion, and I would apply the two-stand for the mediated bifurcation, and then reassess the left main, how to treat. And then, would you please give me the 2.5 NC?
Okay, we will take your time, and so Dr. Kang, you will be back after the Duk-Woo box cases, right?
Thank you.
Duk-Woo box, can you hear me?
Okay.
All right.
Can you hear us?
We can clearly see that, and so.
Okay,
you
so
understand.
thank you for
Yes.
joining our live case demonstration. This is another very interesting left main PCI, and we will have a lot of points to discuss. And before starting the live case demo, I will introduce our team. I'm D.W. Park from Asan Medical Center, and the Kyusup Lee is a professor in the Daejeon Seung-Mo Hospital. He is our alumni, and Seung-Jung Lee, our senior fellow. Okay, Dr. Lee, can you present the patient background?
Thank you, Professor Park. I'm Seung-Jung Lee. Let me introduce the case. 72 years old male who underwent PCI at +2 distal circumflex 17 years ago and left main to proximal LAD 6 months ago, was admitted for first chest pain. Next. His past medical history was diabetes, hypertension, and hyperlipidemia. And his clinical presentation is unstable angina. Next. EKG showed normal sinus rhythm. Next. Chest X-ray showed normal. Next. Echocardiography showed normal LV systolic function without regional wall motion abnormalities. The left coronary angiogram showed the disease progression at left circumflex ostium. Next. This is his previous PCI image 6 months ago. Left main to proximal LAD and medial PCI was performed. And proximal left circumflex artery showed moderate to severe stenosis, but the distal flow was quite symmetry. Next. This is his coronary angiography. Hsieh showed patent previous stent, and then Hsieh colder view showed the previous stent was patent, but the proximal lesion slightly disease progression. Next. At the spider view, the proximal left circumflex ostium was disease progression, and we performed FFR, the left circumflex arteries, and it showed 0.60 at hyperemia. Next.
When was deployed the main stent in? When?
6 months ago. So I'm gonna briefly introduce this patient, 72-year-old male, and have a diverse risk factor, diabetic and hypertension, and hyperlipidemia. And 6 months ago, and we do left main PCI, the crossover from the prox LAD to the left main using the Megatron from the Boston Scientific at that time, 6 months ago. And the sulcal ostium looks okay, as shown in the before slide, but the patient recently complained the new onset chest pain and the aggravating chest pain. There was a unstable angina the presentation. And we checked the coronary angiogram again. There was during the 6 months period that there is a rapid progression of the sulcal ostium. So we already checked FFR at the time of coronary angiography, and the FFR value was as shown the figure, it's 0.60. That was absolutely hemodynamically significant. That would be culprit lesion for the patient symptom. So looking at the coronary angiography, this is a spider view. 6 months before done, left main prox LAD stent was absolutely good, nice. But the sulcal ostium it seems like a very tight stenosis. There is some haziness. And next view.
Great.
Next
Does
view.
any
the 처음 view, your coronary angiography. Okay. 자, 더 전에 거 epicaudal view. First view. Okay. This is the as you can see the areocoral view, and the left main ostium is there is some a mild stenosis. The sulcal ostium seems to be a significant narrow. And next one. And this is the epicranial view, and the prior stent, the mid LAD, and the left main stent looks good, and there would be some aneurysmal change. And next one. And this is next one. This is the spider view. As you can see, the circum territory is not small. FFR absolutely is less than 0.8, 0.6, and so our today's target lesion was sulcal ostium. How gonna treat? This is absolutely a lot of debate, and the prior left main PCI, and at the time sulcal ostium is okay. Now it's newly compromised the sulcal ostium after stenting crossover to the prox LAD to left main. This is debatable portion. How gonna treat such region?
Okay.
Any discussion from the moderator and the panel?
This is complication of stent procedure for that. Yeah. All right. Anyway, I want to just let you know, even FFR is representative of ischemia, right? And depending on the cutoff value, 0.6 is very low. Yeah. We got some data. Up to 0.65 something is related with hard endpoint related. There's MI, something like that. However, 0.79 between the gray zones, 0.65, 0.8 something, is more related with a soft endpoint, repeat revascularization, etc., etc. And so even the number of FFR is sometimes very, significantly related with, clinical event. And so we don't have any doubt about, for the stand for this region. So, Dr. Buck, how would you do that?
So, and we are trying to evaluate the, anatomic lumen, inner side of the lumen, and we try to go through the IVUS castra and does not through the sock osteum. So we did 2.5 compliant balloon. Can you show us the time of a compliant balloon, the angiogram? So, and we evaluate after implantation of the compliant balloon, and we evaluated LAD part and sucker part, and we did wire is easily faster. There was a 2.5 compliant balloon, and then we evaluation whole segment of the suck osteum as well as LAD. Okay, can you show the suck IVUS from the distal to the proximal os? Okay, this is Boston Scientific IVUS, and this is a new version of ABIGO system. ABIGO system is the AI assistant measurement of a target region. This is very useful, newly adapted in our practice, and somebody already experienced the ABIGO system. As you can see, the sock osteum is very tight, and the distal overlapping part, there is could you show us the distal part? There is some severe calcium. Is a lesion is very tight. Even after applying the 2.5 compliant balloon, the lesion is very tight. Also here in the we evaluated the target lesion socket territory, we're gonna apply the ALA system in the ABIGO, and the ABIGO is absolutely AI assisted analysis, and the ALA is automated and the region assessments. They're gonna show the lesion length as well as target the narrow the portion. This is ABIGO system. Is the most narrow the part. That is automatically measure the tightest lesion and the vessel size as well as the lesion length. And we are used ABIGO system in the several patients. Overall is good, but sometimes severe calcified region and some ugly lesion do not match, but this overall accuracy is, I feel personally is good. And the very narrow part is the lumen area was just 1.88. The vessel size was approximately 10. So, and outer vessel, the longest diameter is 3.9, the shortest 3.2. So I'm gonna apply the 3. If you're gonna select a stand, I'm applied on the basis ABIGO ALA automatic lesion assessment. I will apply the 3.5 stand.
Yes.
Also, we measure the LAD to the left main. So could you show part of the sock osteum coming? The left main stand was very expanded. Some distal part, there is some aneurysmal change, but it's a very, well opposed. The prior stand is well expanded. Okay, at the point of the sock osteum coming, the 6 o'clock, and could you apply the ALA, automatic lesion assessment? So this part, and evaluated the inner side and the outer side. So, and lumen vessel size is very big, and the smallest part, lumen area is 12, and the longest diameter is 4.2, shortest 3.7. We're gonna apply the 2 kissing stand to the sock, and the final kissing, we can adapt a 4.0 non-compliant balloon would be good for final kissing balloon dilation. In our catheter, we will use the 100% imaging guided PCI, and we are freely use the IVUS or OCT nearly and half, and so this is our typical example of imaging guided complex left main PCI. So we shows everything for the imaging evaluation. Any comment or any suggestion? My key question to the panel and the audience and the moderator is how gonna treat the sock region, and somebody concerned about the too much stand overlap, and there is some option. We can put the stand, or we can put the TB, or just we can put the balloon angioplasty and final kissing. And what you gonna do recommended for this patient?
Any suggestion?
Yeah, no, I think the Yves was very helpful. I mean, yeah, you can see that the length is actually more than 20 millimeters. I mean, I agree. I mean, my choice would be to place a stent, try to connect it from the old stent and come back to the ostium of the circ, and end with the final inflation.
Yes. Another question is if you agree the stent implantation, which technique? We have some diverse technique. We can do a minimal tap, TN protrusion and final kissing, or we can do Gullo technique, or we can do reverse the crush technique, and there are some three techniques. The universally most commonly used the complex left main bifurcation lesion, and which technique you prefer?
You see, I would probably go with a cutting balloon and then use a DCB, see what your result is like. If the result is acceptable, I would stop there. If the result isn't great, then I would probably consider the T with TAP approach here. I wouldn't personally be doing Kilot into this and adding 2 layers of stents.
I agree with you, Mamas. The same. I have a question. Looking at this proximal left main and LAD, is there a difference in diameter between both?
Yeah, absolutely.
How much is the difference in diameter?
Mid-circle part diameter is 3.4 and 3.5, and there is absolutely discrepancy. Left main diameter is at least more than 4.0, 4.3, and 4.5. There is some size discrepancy. So if you consider Gullo technique, there could be some size mismatch.
It will be difficult with this. Personally, I will do distanting.
So I'd like to one comment, as you mentioned that there is a size discrepancy between left main and circumflex proximal part. So, and then there is a wide angle between the left main and the circumflex. So that's a good indication for the tap technique in this situation. So why not just use the NC balloon, Razi NC balloon for circumflex balloon angioplasty first, and then see the result. If it's really good, as Dr. Mamas mentioned, that the DCB can be a good option. But if balloon angioplasty result is not so good, in that situation, tap technique will be good choice.
In EBC, we are beginning.
I think
we are beginning a trial with DCB to treat bifurcation lesions. So both branches, only DCB, and but this is not non-left main for the moment.
I think for me,
so we will do balloon angioplasty first. So we are still concerned about the many nowadays some booming about the DCB application for the left main bifurcation region. We have many experience with DCB application for sarcoosteum. My feeling is almost all cases showing very severe dissection. Although angiographically looks good, if you do imaging, there is a severe dissection. My fundamental feeling is not good. Just leave it alone. DCB, it's angiographically some ambiguous. I'm not make sure is that patient is absolutely good for the long-term follow-up.
I agree with
any experience?
Yeah. Okay, so I think it's because DCB might be possible, but it's very heavily classified region. So when we try to making a very good preparation of the region, I think it's maybe we have a very big dissection. So I wonder that in the DCB, it's not so good option in this situation. Maybe stent implantation is much better.
Great. So how would you do that, Dr. Park?
Yeah. So firstly, we discussed the live case, the people and the meeting and with SJ Park and our team and our plan. Just the balloon angioplasty sarcoosteum and applying TEB not work, and we guess. So we are trying to do finally 2-stent technique. Among the 2-stent technique, Gullo would be not good option for there is considering some size discrepancy, and we are first consider and the reverse crush technique would be some another option. So now I put the 4.0 NC balloon to the LAD, and then we apply this is a 3.5 NC balloon.
NC 5. So finally, you're going to do the reverse crush or something?
3.5. Absolutely. Yeah. 3.5.
All right.
Okay. Deplete.
Okay, well, I don't believe,
자,
any
3.5,
which kind of two-cent technique would be
3.5.
good or not. Louvard may you
20.
did not agree that, right? However,
Okay.
finally, the stand areas
20.
after the two stand, how much we can get minimal stand area is the most important predictor for long-term outcome for the main disease. We got to get some new cutoff value in 6, 8, 11 something, right? And however, particular this case is actually the angle of circumflexion LAD is quite stiff. It's almost 90 degrees, and we consider technical point of view the T stand just match it stand for the ostium of main stand. However, personally I prefer DW also, and reverse cross is quite safe. Anyway, final kissing balloon inflation, we want to make a big stand area. So that's maybe that's the next step would be there.
Yeah, no, I agree. And I think given that there is a stent already in the left main, you can use any of the stent boost techniques when you're placing the stent so that the amount of stent jutting back into the left main, you can minimize it and use any of the crush techniques.
Okay, I applied a very aggressive NC balloon using 3.5 after seeing coronary angiography, and the panel had the additional comment. Okay, 자, 준비됐지? 자, 여기 한번 찍어보자. Ready? 자, 풀샷. Okay. So, what is the next step? And I think some audience it would be some interesting findings. IBUS. I'm going to check it up. The IBUS. Okay, IBUS. So, at this moment, I very aggressively applied the NC balloon 3.5 up to 20 ATM.
Still
6
right.
or 7.
Large
attempt,
residual
and then
stenosis.
I'm gonna evaluation. So I think at this moment we're gonna apply the DCB. Overall shape would be same. Yeah.
That's why you should do a cutting balloon. I don't think that the expansion's great with a non-compliant balloon. So go with a cutting balloon and then apply the DCB.
Okay.
I think
This
at
is
this moment,
prior stand, the
result in
proximal
that
part.
meet the
Okay, there is
criteria
some,
to
you
use
know,
the DCB.
Calcium
residual stenosis more than
multiplication,
30%.
and there is some dissection, there is some calcium protrusion. This is a suck. Okay, this is the ostium of the suck. 0.5로 보고 있죠? 당연히?
예.
풀백. Okay, so can you show again? Okay, so and this is prior the stand, and there is some, as you can see, there is some plaque protrusion, there is some dissection. As you can see, the calcium was cracked. So, and we will apply the TCB. Just we'll let them be just at that status without any, the stand, the modification. So, and you after seeing the IBUS. And what's gonna do your next step? Any comment? Is everybody think about the DCB would be okay for that patient?
As I mentioned, the residual stenosis is more than 30%, so that did not fit the criteria to use DCB only. Although the TME flow is 3 and no severe dissection, so I suggest we should put a stent at this moment.
Yeah.
Thank you.
Stent
In terms of
So-
DCB, you need more data, right?
Yeah.
For the
So as you mentioned, Professor Youngkeun, you can apply the TCB in the sarcoma, but as shown in the many cases, if you do pre-preparation, NC balloon, cutting balloon, and another balloon, there is some severe dissection. The distal part would be okay, but the proximal part, sarcoma, very severe dissection. We not make sure that patient outcome would be okay during the follow-up. So reason why. So still, we are limited the application of the DCB for the sarcoma, and we need more additional data. So as the plan to before the live case demonstration, we gonna apply the additional stent to fully cover the suck part ostium. Okay, 와이가 너무 깊다, 그제? Okay. So this is a 3.5 and the synergy stent. Okay, fully cover, and then I'm gonna pull back the left main, the 4.0. Okay, so I will do reverse crush and slightly pull back the more over here. Okay, so I'm gonna check it up the stent booster to overlap the distal part. I think the distal part is absolutely overlap well. Okay, good. 자, 천천히.
네.
자, okay, we're gonna check it up angel here. Okay, pull shot. Okay. So I think there is fully covered the suck ostium as well as a prior stent. Any comment at this moment? It's not yet. 좀 들어갔다, 그지? Okay,
pull down.
test.
Okay, great. Mini crush.
Okay.
Pull in.
자, 조금만 더. 오케이, 테스트. 잠깐만 좀 나올게.
그래.
조금 빼도 상관없어. 숨 천천히 쉬세요. 숨 조금 참으셔야 돼요, 선생님.
Good position.
오케이, 테스트. 오케이, 고. 인플레. 오케이, 11.
10, 12.
오케이, 디플릿.
Depression.
뭐 풀백. 오케이, 10, 12, 14. 16.
14, 16.
Okay, deflate.
Depression.
So before removing the stent balloon and the wire, we're gonna at this moment apply the additional high pressure using NC balloon for much
Great.
easier re-access the suck ostium wiring and the NC balloon 3.5. Okay, 천천히. Okay.
Okay,
This
talk about
left main stand
talk
is
about
4.0.
Dr. Bach. Can you hear me?
Yes. Okay, I can hear you well.
So
3.5.
we have limited time, and so we want to move to another room, Dr. Kang's
Okay,
cases,
thank
and
you.
we'll
Okay.
be back soon, right?
Okay, thank
All right,
you.
Dr. Kang, can you hear me?
Yes, I can hear you.
All right, what I do? What
Yeah,
have you
thank you
done?
for giving me the time.
All
What
right.
I learned from the SJ is that D4 is good, but if we decide to treat, we should treat aggressively to make perfect result. And I did the two crush technique to diagonal and LAD. I circumflex and covered all LAD with one stent. Let me show you the process. And okay. So because the dissection was the significant and the diagonal was big with the collateral feeder, next. And I apply next. We decide to open everything. Next. And this is the 2.5 NC to fully open the calcified diagonal. Next. And this is 2.5 26 millimeter onyx stent, and with a 3.0 NC to cover the main branch. Next. And the stent was well expanded. Next. And I additionally applied to 4.5 NC to fully open the ostium and optimize the circumflex stent. And this is the result. And next. And then I crushed with the 3.0.
What about
Next.
the stent lengths for the diagonal stent?
That was 26.
26. All right, great.
Yeah, because there was some disease region, and there was no very good landing zone. The stent length was a little bit longer than expected. Next. And then did the circumflex stenting. There was some indentation with the ballooning. Next. And after more aggressive ballooning, next, it was opened. And I applied more with a 3.5 NC with a short balloon. And
Open
you
up
can
the
see that
ostium.
the diseased
Circumflex
ostium is
open,
fully
right.
expanded. Next. Yeah, this is the result after putting the stent. And next. And I crushed. And before crush, I fully opened the main vessel with a 3.5 NC. Next. And next. And next. As you can see, the 3.5 is small for this. So this is 4.0. I additionally push it the
Crush,
side branch
balloon,
stent.
balloon
Next.
crush, right?
Yeah, it was balloon crush, and then applied 3.5 by 48 cent, just one, and covered all main to LAD region. Next. And then optimization with a 3.5 and 4.0, and next. And for the left main, I could see that there is some on barrel position and apply 4.5. Next. And now we are here. I will check the NGO. Yeah. And now it's time to open the openings of the side branches.
So you're gonna do the
I believe it will not take so long.
kissing balloon inflation for diagonal dose and
Yes.
the main dose. Right?
Yeah. I will do the step-by-step diagonal first and optimize the LED diagonal side branch. And next, optimize the main branch bifurcation. And this is the shown wire that I've used before for diagonal wiring. And do you have any question or comment for the steps that I did till now?
All right. And geographically getting better, right?
Yeah, no, absolutely. And I think this was a safer strategy because the diagonal, not only at a dissection, there was a hematoma also. So I think this is much safer.
Yeah, I believe, angiographically good, result is usually good clinical outcome. I believe so.
That's right.
So anyway, main bifurcation region, you apply the two-stent, right?
Yeah.
However, if you look at I was finding a very discrete narrowing, and the region lengthwise is less than 10, millimeters. So Louvard, you presented your EBC, new data in terms of a provisional stand. Would it be better in terms of a region length less than 10 and relative, ostial size was small? Would it be better than that? Would you explain that one?
We have the result of EBC men at 3 years now. And of course, in the single stanting, the crossover was allowed. So depending on the result, this is the spirit of provisional. You look at the result and you change your mind. And in the systematic double, frequently was done as following the systematically the provisional strategy with culotte, which was the most used double stanting in ABC men. And we have the result at 3 years. There is a better, a lower amount of MACE at 3 years in the provisional group. And there is a trend, 0.1, there is a trend for a lower mortality at 3 years. So we discussed this frequently with Youngkeun. I mean, the patients we are treating in Europe, especially in my country, and the patients who are treated in China are completely different. So you may justify probably in China to use this strategy as well, which was shown here. But regarding this lesion in particular, I would have done differently, so I cannot tell you if it will be better or not. Provisional would be my choice. T-stanting for the left main, and maybe after dilation of the diagonal and dissection, maybe stanting from LAD to diagonal and a kiss of the DCB in the LAD. So that's the solution.
Deflation. Training. First, I tried to close the 2.5 and see that was used before, and I changed it to Do-Yoon deflation, and easily passes, and opening the ostium with a balloon anchoring training.
Anchoring and small size balloon pass diagonal branches.
2.0 compliant balloon deflation. And you should open more proximal than you think, because bifurcation is
Actually,
here.
this case is morphologically really complex one, right? Diffuse, long region. However, I think a little bit changes in terms of a complexity concern. If the interventionist can make a good angiographic and Ives optimization, etc., the result-wise is relatively good. For example, for particular this case, right, region length at least 50 millimeters, and you're going to make a 3-5 stent, right, stenting. Effective stent area is more than 5.5. If we apply the 3-5 stent, maybe stent area more than 7 something. The restenosis rate here less than 2%. That is our data. So that is a little bit changing concept. In a syntax studies, almost 15 years ago, 10 years ago, they got no idea about, anyways, FFR and Ives guided, etc., etc. And so I believe we've changed in terms of, contemporary PCI, Ives guided, high pressure optimization, and treat or not treat FFR guided. That's a totally different yield. We're going to move to, PCI. And so I believe CABG is clearly better in some cases. However, we've changed it. Personally, I think so, right?
So thank you, Dr. Park. But I have to say, I've been going to cardiology meetings for 20 years, and no one has ever shown a bad result. I've never seen a bad result. But the difference between what looks angiographically very good as an early outcome is not the same as what's happening 20 years later. The mean age of patients...
20 years later, you mean?
10 years.
10 years, right. It's okay.
So what many patients are looking for are long-term outcomes if they are low risk for an operation. So this looks a superb result. I often see this, but I also see the patients who come back whose initial early result didn't stand the test of time.
Good. So
we have the 10 years syntax results, without difference. 10 years. Maybe wait 20 years to see.
So, Dr. Kang?
Yeah.
Okay, would you explain that? What would be done?
Yes.
We're almost there.
I've done the kissing ballooning of the diagonal and LAD branch and check the angio minus.
And then you want to do the kissing balloon inflation of the main dose?
Oh, yes, not yet, but I want to check the diagonal and forget everything about the diagonal branch.
Great.
And I will move to left main.
Anyway, I like the angiographic result. All right, you're going to move to the Dr. Kang really complex cases. I'm happy to
thank you
with us.
so much.
And so we're going to move to Dr. Park. Where are you going?
Okay, so we will explain some prognosis. This is okay. 아까 그 와이어링 스탠 하는 것부터. So 오케이, 저 밑에서 세 번째 위에 그렇죠, 그 위에. 아니, 저 스탠 딱 매치할 때 찍은 거. 그렇죠, 오른쪽. 오케이. So and at this is booster. I'm gonna make sure the stand is some overlap the fully covered ostium. Next one. So on the basis of the IBUS, I put the 3.5 the synergy stand. 내가 넘길 때 넘기세요. Synergy stand and the 3.5 24 and the implantation and the LAD balloon is 4.0 NC balloon and the next one. So and the slightly pull back and the additional high pressure using the stand balloon. Next one. And this is a very sensitive step. People removing a wire. And I applied the very aggressive additional NC balloon, the 3.5 NC balloon, and then next one. This is the NC balloon. I inflated up to 24, 26 ATM NC balloon. Next one, and then this is the NC balloon is additional to 3.5 or 26, and then next one, and then this is additional very aggressive the NC balloon. Next one. Additional next balloon. Okay, and then remove the wire sock. I apply the crush, reverse crush. This is a 4.0 NC balloon, the LED part, and the next one. So, and this is the how much, and the next one, there was the stent boosting and the make sure the right position, and the next one. So this is the 4.0. I applied the 24 ATM fully the crushed the sucker ostium. There was a key step of reverse crushing, and the next one. So this is just the immediate crush, and angiographically there is some heaviness of the sucker ostium. I'm not make sure is the inner part is what's wrong. And next one. So I tried to the rewiring using the Hsieh blue wire, our household wire, and easily push the LED part, and this is key step, and then slightly pull back, and the next one. And the wire is the reinsertion is key step. We try to the middle part, or the proximal part would be okay, just avoid the distal part. So, and I take time, just 10 seconds. Is a wire is passed well. And next one. And then put the LED additional NC balloon 4.0 used balloon, and then initially try to anchoring the left main 4.0, and then try to push 2.5 used balloon, compliant balloon is luckily passed well. And then next one. And then the high pressure balloon, the 2.5 compliant balloon, 2 passage additional NC balloon, next one. Next one, next one, and then I'm gonna change it. This is the use the 3.5 NC balloon. I did a very aggressive NC balloon high pressure inflation. Next one, and the next one. This is the final step of the Kyusup balloon. I did suck ostium high pressure inflation up to 25, 26, and then a sequential high pressure balloon. Left main part, that 4.0 up to 24, and then next one, I do apply the 12, suck ostium 3.5 NC balloon, left main is a 4.0 NC balloon, and the high pressure balloon at the one time. Next one is 2 time. Next one, this is 3 time, and the remove, and the next one. So this is immediately the angiography, and I'm gonna check it up the suck Yves. Could you show the suck? How much change the inner part? This is distal part is overlap, and we can see the overlap the stand over here, in the quite expanded the previous calcified region, and some part is slightly eccentric, but lumen is absolutely okay, and you can see the polygon of confluence on how much crushed well. This is the proximal suck, and the suck ostium is just coming. Okay, okay here. Okay, so could you show us again slightly before? Okay, start again. And as you can see, there is just 1 or 2 strut. Carina and the suck ostium was fully covered and expanded well, and I think there is a typical case of reverse cross technique, and fully covered the suck ostium, and geographically looks good. So I think we have a very cutting edge knowledge about the use of the TCB and the new version of the TES and any other additional options. So I think make sure if you're gonna just apply the DCB, you don't have a good sleep at that night. But you put the additional stand like this, you would have a good sleep. So that is our moment, and I will the final check it up the left main part from the prox LED. This is nearly final angio. Any comment or any suggestions?
Really perfect cases, right? And I think it's a kind of a very difficult one, and still, I believe the bigger better, the bigger the better, and the angel and figure good is maybe the better, right?
Yeah. No, I think beautiful result and a good demonstration of 2 complex cases. Just as we move on to the next one, first of all, congratulations, beautiful cases.
Thank you so much.
Okay, so we'll move on to the featured lecture. So this is on left main and multivessel disease revascularization, updated guidelines and beyond by Dr. Hsieh Park.
All right. We've seen many cases about main stenting and multivessel stenting. Right. If you look at the underlying data, revascularization for multivessel disease, actually relatively old ones, right? Look at this, 1983, 2000. Meta-analysis, recent one, CAS, stitch, carriage, very 2D, freedom, syntax, even best trials. CAS trial is almost the first randomized studies, bypass surgery was medical treatment. They included multivessel disease, and clearly very old study. Didn't find any statistical difference in terms of over medical treatment, bypass surgery would be no difference at all. However, they found patients who had a low ejection fraction and cerebral disease, maybe bypass surgery would be better. Still, the conclusion is not clear difference. And so, if you look at some ACS guideline consent, cutoff value ejection fraction 50% from this old CAS trial, right? And the next, stitch trial, the surgical treatment ischemic heart failure, less than ejection fraction 35%. Divided with the surgery with the medical treatment, including the multivessel, is almost 90%. 5 years data, first presented statistically not difference in terms of all deaths. 10 years data, statistically difference is very big issues, and bypass surgery is clearly better for medication. Patient with multivessel disease and ischemic cardiomyopathy, less than 35% of ejection fraction. This is the old one. Courage study, no survival benefit of PCI. Very 2D study, we are concerned about the diabetic multivessel. PCI had no benefit in low-risk patients. However, bypass surgery is better over medication, high-risk, patient group. Freedom study, diabetic multivessel, 5 years, heart endpoint, death, MI, stroke, clearly surgery better. A syntax study actually combined the main and multivessel. This is a subgroup analysis. 3 vessel disease, 10-year old deaths clearly better in bypass surgery. If you look at the meta-analysis, bypass surgery versus PCI at 5 years, definitely surgery better. In case of a diabetic patient and multivessel disease, clearly surgery is better. Non-diabetic remain actually not statistical difference between the two. So look at this. All study for multivessel disease have shown significant difference in mortality concern. However, look at this. This is our best trials. At 10 years old, there's actually no difference at all. This is first, not different. Only data showed no mortality difference between the PCI versus bypass surgery in multivessel disease. And we moved to the Yves guided, started with the FFR guided. Look at this. This is all data. All study used the bare metal stent. Even in the very 2D studies, more than half bare metal stent. 35. Freedom studies, Cipher, Texas, first generation. Look at this, syntax, Texas. And main issue is lack of concept of FFR and imaging. So 2018, before the ischemia study, look at this. We cannot do PCI for the multivessel disease. Even in the low syntax, the patient with the diabetics don't touch. That is, ESS guideline. However, 2021, look at this, multivessel disease, they separate whether depending on ejection fraction less than 50%. This data, from the CAS trial, very old study, suitable candidate for bypass surgery, class 1. Low ejection fraction, definitely 35, less than 35%. However, normal ejection fraction more than 50%, even in the 3 vessel disease, actually bypass surgery, PCI, any revascularization was classified 2B. So we, clearly defined the, efficacy of revascularization. However, I really ischemia study, 2020. the only data that influence the concept of FFR and arterial intervention. You know that, multivessel disease, stable ischemia, stable coronary artery disease, moderate to severe ischemia, separate with initially invasive, initially conservative, 76% multivessel disease and severe ischemia, randomized to ischemias, 80% revascularization, 74% PCI, 26% bypass surgery. Not too much incidence of bypass surgery. However, we wanted to separate conservative. And they have included the concept of FFR. PCI is recommended more than 80%, size-wise 2.25. PCI is not recommended, diameter is less than 80%. However, unless FFR positive, don't touch. If FFR is unavailable, intravascular IVUS, minimal lumen area would be, criteria for treatment, etc. Anyway, primary endpoint, no difference at all deaths, myocardial infarction. Even in terms of primary endpoint, subgroup analysis with the different severity of ischemia, moderate, severe, in the presence of a diabetic, non-diabetic, even in the no difference at all. With diabetics, here, no difference between the invasive conservative treatment, anatomic complexity, one vessel, two vessels, three vessels, actually not too much difference. Proximity disease, no difference at all. And extended 7 years follow-up, no difference at all. So what if wrong from the ischemia study? No survival benefit of invasive strategy, mainly included the PCI, and optimal medical treatment is good enough for majority of patients with stable coronary artery disease. William Fearon's meeting present this data. Phase 3, 5 years, actually they define death, stroke, MI, no difference at all. 5 years follow-up data. So ischemia in the phase 3 trials are the only study demonstrate the no mortality difference between the contemporary PCI versus bypass surgery. The meaning is contemporary PCI included, cooperate with the FFR and imaging guided. Already, any guideline, class 1A, image guided, physiology guided. So, all right, guideline concern, 2023 ACC guideline, goal of revascularization, patient with insufficient response to improve the symptoms, we need revascularization. Main disease, multivessel disease, ejection fraction, low ejection fraction, less than 35, CABG, definitely to improve the survival. Patient with diabetics and multiple involving LAD and multivessel disease and CABG recommended, this is guideline concern, and low syntax score, to be classified anyway, the PCI could be done. And the symptom improve is goal of revascularization, 1A. And if you look at the 24 ESS guideline, it will change a lot. Normal ejection fraction more than 35%. Main was 3 vessel, normal ejection fraction, PCI, and bypass surgery, 1A. Anyway, and 1 or 2 vessel, normal ejection fraction, still, 1A. And heart team discussion recommended multi-vessel ejection fraction with a low ejection fraction, 35%, CABG, and high surgical risk PCI would be 2B anyway, we can do that. 3 vessel disease without diabetics, and normal ejection fraction, insufficiency response 1A, and 3 vessel, no diabetic, insufficiency response, and low anatomic complex, low syntax square etc. PCI would be good, and multivessel with diabetes and bypass surgery, insufficiency, anyway, high risk PCI recommended 2A. Anyway, there we have some PCI had some role for the revascularization. So this is my conclusion. Anyway, bypass surgery is better for multivessel. The high anatomy risk, 3 vessel disease, low ejection fraction. Anyway, up to this point, the diabetic patient, maybe bypass surgery better. Right, this personally, I have learned over the past 20 years. visual assessment 50% up to 80% does not correlate with the physiologic skin glands. More than 50%. To believe or not believe, you cannot believe your eyes. And so you're going to start the defined DM study. Diabetic multivessel disease is still big issues to get the answer. And so 3-vessel diabetic patients, we compare with randomized with the state-of-art contemporary PCI standard bypass surgery. Right, I want to move remain briefly. Bypass surgery very old data. Surgery would be better over medication. 15 years of survival is clearly better bypass surgery over medication. And bypass surgery has a better survival over medications. However, still we don't have enough data. PCI versus bypass surgery for main disease, the data quite limited. Syntax pre-combat, double XL study and combined. Look at this, very interesting findings. All deaths, subgroup, syntax 10 years, no difference at all. Mortality concern, all right? You get 10 years data, diabetic, non-diabetic, no difference. This is our study, pre-combat study, 10 years of follow, no difference in mortality. It's a noble 5 years old deaths, no difference. Primary endpoint XL, recent published 5 years, not statistical difference, right? Recent published meta-analysis, syntax pre-combat novel XL study, at 5 years old, that's definitely no difference at all. 10 years of follow-up data, no difference at all. What's different? Unlike in multivessel disease, all studies even in the old ones, the main disease have shown no significant difference in mortalities. There is a big difference with the multivessel and the main disease. All right, this is my talk, David. So if you look at the 2008 ESS guideline, it's quite generous. It's for the main disease, maybe more than 60% of patients would be candidate for PCI. High anatomic complexity would be a good candidate for surgery. Low anatomic complexity would be CABG still 1A, PCI class 2A. So I would ask, what does it mean? High anatomic complexity, high syntax score. If you look at the inside, high syntax score, high anatomic complexity, actually due to concomitant 3-vessel disease. Main sub-studies, high syntax score, 65% of patients included 3-vessel disease, that is ours. All-cause mortality, main only DS better, osteal sharp, and even in the single vessel, main and LAD proxy disease is good. Extensive 2 or 3 vessel disease and multi-vessel disease involved bypass surgery definitely better. So I would say main disease is a little bit different with the multivessel disease. However, issue is main is a high anatomic complexities, main with multivessel disease would be issues, problems. And so we have to focus on the multivessel disease more. So main disease is not a surgical disease anymore. This is my personal opinion, David over there. So patient with the main significant limb disease, high complex coronary artery disease, CABG recommended, poor candidate, PCI 2A, a little bit generous, and ESS guideline changes, significant limb main disease, bypass surgery, low syntax score, low anatomic complexity, PCI 1A and 2A indication from ESS guideline, those. Main with multivessel bypass surgeries, main with high anatomic complexity, main with multivessel, right, CABG recommended. However, high surgical risk PCI may be skewed. And so main 3-vessel, high anatomic risk, LV dysfunction, all right, agree, bypass surgery is better. So I know that the visual assessment is not good. And so we're going to start main trial, the patient who had a main disease randomized with the FFR-guided PCI and angio-guided PCI. Thank you for your attention.
Thank you very much, Dr. Park. And I would like to thank all the live case operators and the panelists and the audience for a wonderful discussion. Thank you very much.
All right.